Just so that you know, Dr. Belagaje is one of our neurohospitalists. That means that he's one of the doctors that takes care of you if you have been admitted to a hospital and
Is it
have
just me, guys, or can you all hear
neurologic
Dr. Parker?
concern. They said they can hear me.
Yes, continue, Dr. Parker. We can hear you.
So Dr. Belagaje is going to talk to you a little bit more about stroke and what goes on in that process. But again, he is what we call a neurohospitalist, which means he takes care of patients with neurologic issues in the hospital. Dr. Belagaje.
Can everyone see my slides?
Yes.
Right. Well, thank you again, Dr. Parker, for the gracious invitation, and it is a pleasure to join all of you here. I've been asked to talk to you about stroke and stroke prevention, and this is I think a timely lecture because February, it was Heart Month, and so we have our usual big stroke conference, national conference in February, and we want to also, it's a stroke awareness month as well. So we're coming at a good time to talk to you all about stroke and stroke prevention. What we're talking about today, what I'd like to is give you a little bit of information about the stroke basics, review the warning signs and symptoms. So what I'm going to talk about today is kind of review the stroke basics, talk to you a little bit about the warning signs and symptoms of a stroke, talk to you about the risk factors associated with stroke, and then evaluation and treatment of a stroke, what to expect if someone comes into the hospital with a concern for stroke, what we do for them, and then end with stroke prevention, because I think an ounce of prevention is better than a pound of cure. So we'll talk a little bit about how we can prevent stroke, and then kind of end with the public's involvement in stroke care. So let's begin with the basic question, what is a stroke? So the technical definition is that it's a loss of blood flow, nutrients, and oxygen to a region of the brain, resulting in neuronal damage and subsequent neurological deficits. And so what that means is the brain itself is dependent on a blood flow to be able to function. The blood carries oxygen and various nutrients to the brain, those brain cells. And when there is a loss of that blood flow, oxygen and those nutrients are not able to get to those brain cells. And as a result, they get damaged, and often they become irreversibly damaged. And the brain is very sensitive. It depends on oxygen, unlike some of the other cells in our body, which can go a long period of time without oxygen. Unfortunately, brain cells cannot do that. And so they become very sensitive when there is a lack of oxygen to the brain. And as a result, that brain part stops working. And as a result of that, what we see is that a person who's experiencing a stroke will develop an acute, so it means a sudden onset of focal neurological findings in a particular vascular territory, which is where that blood flow is as a result of that. And I'll talk to you a little bit more about what exactly that means in subsequent slides. And so why do we care about a stroke? Well, stroke is the 5th leading cause of death in the United States. When I was in training, we was the number 3 killer of people in the United States. But because of continued research and advancements in our field, we've dropped that down from number 3 to number 5. The things that we haven't done such a good job, though, is that stroke is still very prevalent. On average, about every 40 seconds, someone across the United States suffers from a stroke. And every 4 minutes, there is a death caused by a stroke. So we haven't done as well in reducing the number of strokes. And that's part of the reason I enjoy giving these talks, is that hopefully I can provide you with information so that we can continue to see those death rates drop, and more importantly, those rates of stroke incidents also continue to drop. And although we've dropped the death rate, people haven't continued to have disabilities after a stroke. And many of you listening in today are probably know someone who's had a stroke. And if you are aware of that, you know that they may not be 100% back to normal. And as a result, stroke is the leading cause of disability worldwide. The public impact of stroke, as I said, it's very prevalent. We see somewhere between 250,000 to 800,000 strokes each year. And about 4.5 million survivors of strokes are present in the United States today. We talked a little bit about the death rates, which have decreased, but we're still in the top 5. So we still have things to do. And stroke is expensive when we talk about the care that we have to provide for patients, both in the hospital and the subsequent disabilities. And then when we factor in the indirect costs of loss of treatment, lack of productivity, and whatnot. These statistics are a little bit dated, but I still think that they carry the point. In the year 2008, so 15 years ago, stroke cost $65.5 billion to care for people across the United States. And just to put that in perspective, the entire NASA space shuttle program from 1972 to 2011, so that's about 30 years, and then was 196 billion. So that's a cost of over 196. That 65.5 represents 1 year. So if you multiply that by 30, you can see what it does compared to the space shuttle. If you wanted to use that money to build a nuclear class aircraft carrier, that's $4.5 billion. Chump change compared to what it costs to take care of people who have had a stroke. So the bottom line with the statistics is that it's around. It can be deadly. It's costly. So we want to be able to continue to take care of patients who have had them, and then do our best to try to prevent it. When we talk about stroke, we talk about 2 different types of stroke. There's kind of divided into 2 main kinds: the ischemic and hemorrhagic strokes. The ischemic strokes are the most common type, and they're caused by a lack of blood flow to the brain, caused by a blockage of the blood vessel that's in the brain. So what I'm showing you in this cartoon here is we're looking at the cross-section of the brain. The red line represents one of the blood vessels going to the brain, and then we kind of do a blow-up of that blood vessel and look inside it, and what we see is that there is a clot in that blood vessel. And so as a result, it's kind of like a clog in your drain at home. And if you've experienced that, then the water and the fluids that cannot get past that, and they accumulate. Here in the brain, that when that clot occurs, blood cannot drive past that area. And as I told you a little bit earlier, is that the brain is very dependent on the blood flow to get oxygen and nutrients to the blood cells, to the brain cells, excuse me. And if they can't get it, they're not able to function as a result of that blood clot. I kind of think about ischemic stroke similar to the way that people experience heart attacks. When people have heart attacks, they have a blood clot in the blood vessel in the heart. As a result, the heart is not able to function, and the heart gets damaged, and people end up having a heart attack. When people have an ischemic stroke, they have a blood clot in the blood vessel in the brain, and then get damaged there, and they end up having a stroke. It's not surprising that in some hospital systems that ischemic strokes are referred to as brain attacks, because it's that very similar process to a heart attack in terms of the clot forming in the blood vessel. The second type of stroke is called the hemorrhagic type of stroke, and this is caused when a blood vessel in the brain ruptures, and as a result, there's a hole in there, and blood is leaking out of the blood vessel and does not get to the brain, the further parts of the brain. That leaking blood also then compresses the brain tissue around it and causes that area to become damaged. So ischemic strokes are blood clots. Hemorrhagic strokes are blood ruptures in the brain. And this is just a different way to look at it, kind of sideways, that you've got the blood vessels coming from the body, coming up and through the neck and then they branch off, like they look like tree branches, so to speak. And if you've got a clot in one of those blood vessels, that will be an ischemic stroke. If there's a tear in one of those branches in the blood vessels in the brain, people will have a hemorrhagic stroke. We're going to dive a little bit deeper into these 2 types of stroke right now. Ischemic strokes are the most common type of stroke worldwide, and most stroke talks tend to focus on ischemic because 80% of strokes that occur worldwide are due to ischemic strokes. And remember, these are the strokes that are caused by blood clots or blockages in those blood vessels. And they can be caused by a couple of different mechanisms. We have the blockage in the blood vessels in the larger vessels, which can be usually the carotid arteries. The carotid arteries are the blood vessels in the neck, and they can cause blockage that way. That can also be in the small blood vessels. The blockage builds up in these small blood vessels. And we're talking about blood vessels so small, we cannot see them with the naked eye. We need to use a microscope to be able to see them. So they're not that big. And so it doesn't take as much blood clot to form in them as it does in the bigger blood vessels. The third type of cause is an embolic type. And rather than the large vessel or small vessel disease where the blockage builds up in the blood vessel over time, in the embolic type, the blood clot travels from a different source, usually the heart, but it can come from a different location. And then it travels up into the brain and then gets stuck in those smaller blood vessels. As the blood vessels get closer and closer to the brain, they get smaller and smaller, just like tree branches do. And then that clot may get stuck in one of those blood vessels and cause an ischemic stroke. There are some other types of causes of ischemic stroke. This can be caused by inflammation in the brain, where the blood vessels get so inflamed that they form clots and cause blockages so the blood vessels can't go through there. Infections of the blood vessels can also cause a blockage. There can be tears in the blood vessels, something we call a dissection. And then the last main cause is cryptogenic, which is just a fancy word for saying that despite all the testing, we don't know what exactly the cause is. When we dividing up the bleeding type or the hemorrhagic strokes, so if ischemic strokes account for 80%, the bleeding hemorrhagic strokes account for 20% of the strokes. And what I'm showing you here is a little bit of blood on a CT scan. So this patient has a hemorrhagic stroke. And there are several types, just like ischemic strokes, there are several types of hemorrhagic strokes. They can be subarachnoid hemorrhages, which are usually caused by an aneurysm. Aneurysms are ballooning of the blood vessels, so this can occur for a variety of reasons. Usually we don't know exactly why that occurs. That blood vessel balloons out, and if you think about a balloon if you blow into a balloon and it keeps getting bigger and bigger and you continue to blow into it, it will pop and the air will escape. Same thing occurs in the blood vessels during an aneurysm. The aneurysm can get bigger and bigger, and then it stretches so much that it tears, and then as a result, blood will leak out and lead to a subarachnoid hemorrhage. Usually, patients who experience subarachnoid hemorrhage will experience a sudden onset of worst headache of life. So not like a typical headache, but a really, really intense headache with very bad nausea and vomiting as well. There are also traumatic types of bleeds that can occur, that's usually caused by trauma, usually like a motor vehicle accident, or in the case of Natasha Richardson, the actress, she had a skiing accident, went down the hill, bumped her head, I think it was against a tree, lost consciousness briefly, got better, and she looked fine and went back to her hotel room and was found subsequently later to have a large amount of blood because she was unconscious at that time. And so the epidural and subdural hemorrhages there. And then the intraparenchymal. So this is blood that is within the blood, the brain tissue itself, just like in the picture I'm showing here. And so it will, the blood vessels rupture in there, and then the blood will accumulate there and cause the intraparenchymal hemorrhagic stroke. When we kind of divide them up, again, as I told you, ischemic strokes are about 80 to 90%. The hemorrhagic strokes are about 15 to 20% of strokes, depending on which statistics that you look at. And when we divide them up with these ischemic strokes, about 20% are that atheroscerebrovascular, that large vessel disease. about a quarter of those ischemic strokes are about the small vessel, the smaller blood vessels. 20% are that cardioembolic or that embolic where the blood clot travels. And then about the remaining is about 30%. Well, excuse me, the 5% is about others, those rarer causes. And then about 30% of strokes are that cryptogenic where we don't know exactly what causes that. And that is something that's an area of research where we're trying to understand, well, if there's a third of patients who come into the hospital with a stroke and we do all the tests that are available, we haven't found a cause. And that doesn't mean that we haven't looked. It just means that sometimes the tests are not regular and they might need either further testing, which we're getting more advances on, or we have to develop better tests and better technology to determine what exactly is causing the stroke so we can prevent it from happening again. And I like to mention that number because if you look at that 30%, that's a pretty big number. That's about 1 in 3 patients who come into the hospital. They come in with a stroke and we say, we're not sure exactly what caused your stroke, which is not that unusual when I see these patients in the clinic. Let's dive into this a little bit more as well. So large vessel atherosclerosis, it's the most common underlying pathology, which leads to the formation of plaque. So that's that blockage. And that's second to the lipoprotein cholesterol, the LDL, that builds up in the arteries and supplying the brain. So I showed you that cartoon earlier of the blood vessels where blockages build up there over time. And initially, blood is going to continue to go past it, but that blockage can build up over time due to other medical conditions. And then it gets to a point where it gets so severe that the blood either cannot get past it at all, or travels, only a little bit of blood can get there so that the part of the brain which is being supplied by the area isn't getting adequate blood flow. And I mentioned this low density lipoprotein cholesterol, which is LDL, because if you go to your primary care doctors, you will see when they do an cholesterol testing on you, you'll see this number, the LDL, and that's that bad cholesterol. So this is what we want to decrease in people's body, as opposed to the HDL with the high density lipoprotein cholesterol, which is a good cholesterol. It seems to be protective against these blockages, whereas the LDL is the bad cholesterol and builds up in these arteries. And then as a result, as I told you, these plaques will continue to block or decrease the diameter of these blood vessels. And this is just kind of a cartoon showing how this occurs. Initially, the plaque is just kind of smooth over time and just kind of builds up over time. There might be a little bit of rupture because it's putting pressure on the blood vessel, which forms blood clot on the surface there, which adds to that density and that reducing the diameter of the blood vessel. And then that can either narrow, or a piece of that blockage can break off and travel further into the blood vessel and get stuck in a smaller branch and cause a stroke there. Or it can completely occlude in where it is and cause a bigger stroke. And so this is the way that atherosclerosis, or that blockage, can cause ischemic strokes in these two different ways. But you can see that it's a buildup over time. Initially, it's just a typical atherosclerosis plaque, which is usually just cholesterol, but then it's going to be made up of platelets, which is the blood clotting factors, some fibrin, which is the proteins which help the form blood clots as well. So the other main mechanism is the cardioembolic or cardioembolism mechanism. As I showed you on that previous slide, about 20 to 25% of strokes are caused by this type of blood vessel. And rather than the clot forming in the blood vessel, this clots will travel to the blood vessels, and usually comes from the heart. And this is kind of showing you a schematic diagram of the heart. So if you think about what the heart does, the heart is a pump, pumping blood all over our bodies. If there are any abnormalities in the heart, whether it's an irregular heart rate, which causes the heart not to beat regularly, or some abnormality in the heart, either some damage done to the heart blood clots will form in the heart. And as a result, the clots will then, piece of the clot can break off because the heart's continuing to pump, and then will travel in the blood. And then the first blood vessels are usually quite big, so they're not going to get stuck there. But then if they travel north up into the brain, those blood vessels tend to get a little bit smaller and the blood clot can get stuck there. The other main mechanism is a small disease type blood vessel. And we kind of talked about this earlier. So it's the same type of process as the large vessel process, where the blood clots are in these blood vessels that are so small, they're less than 15 millimeters in diameter, and they cause very small strokes, but they tend to be in very important areas in the brain. And as a result, because they're so small, it doesn't take as much blood clots to form in them. And as a result, clot will form, and then that area will get stroked and get damaged. And this cartoon here is to illustrate that process that's going. These strokes occur. Usually they're caused by uncontrolled high blood pressure. The high blood pressure causes this process called lipohyalinosis, which you don't need to know. It's a fancy medical term saying that high blood pressure causes a stiffening of the blood vessels and a thickening of those blood vessels. And again, because these are so small, there's not much room for the blood to travel if they thicken up. And as a result, blood can't get through and form blood clots. The other problem with high blood pressure in these blood vessels is because they form that that muscular area of the blood vessels. They're very fragile to begin with because they're very small and they're very delicate. So if there is too much pressure in that area because of high blood pressure, and there's too much of that weight of the muscles, those blood vessels can tear, and as a result, bleeding can occur in the brain. So small vessel disease process caused by high blood pressure can cause ischemic strokes. They can also cause the bleeding type of strokes as well through this process. Let's talk a little bit now, shift gears and talk a little bit about the warning signs and symptoms of a stroke. These are some typical stroke symptoms. And usually people will experience sudden onset. And that's the key when you're worried about stroke-like symptoms. This is not symptoms that occur over a week and say, oh, I'm kind of gradually got numb, kind of started gradually. And then over a day, it's just been kind of progressing. No, in these situations, it's one moment I was fine. The next moment, all of a sudden, I got weak. And one of the challenges in stroke care is that when you look at this, there's not a set number that people need to have, or that you need to have every single one of these symptoms. Patients who have had strokes can have just one of these symptoms, like weakness or imbalance. They can have a couple of these symptoms: weakness, loss of ability, numbness, dizziness, or they can have all of them. And it's just dependent on how big and the stroke is, and where exactly that stroke is, with a blood clot or stroke, which part of the brain it's affecting. And I'll explain that in a little bit. But this makes stroke care challenging, and why people have trouble sometimes recognizing a stroke. I always think about kind of strokes, especially in the acute setting, as like heart attacks. I think, to me, heart attacks are a little bit easier because you can talk about chest pain, shortness of breath, or kind of that sweating. And those are kind of the main combination of people who tend to have those. But when you look at the stroke symptoms, they can vary. And it doesn't have to be weakness in all over. You can be in weakness in one arm. It can be in weakness in the arm and leg. It can be in weakness in all four limbs. You can have visual loss in both eyes. It can be in one eye. It can be in partial of just one eye. And so that's what makes stroke challenging at times, because there's not a key set. The other part of this is, as you look at these symptoms that patients tend to present with, is they're not exclusive to stroke, that there are other mimics that can cause this. People who have pinched nerves caused by a spinal process can develop weakness. They can develop numbness as a result. People who have, due to medication side effects, may develop imbalance or dizziness. or if they're dehydrated, or if they have infection, can develop some of these other symptoms. So one of the challenges that we have in stroke care, both in the acute healthcare setting, is deciding if somebody's truly having a stroke or are they having a stroke mimic a different condition. And then if we're as healthcare providers struggling with it, you can imagine what the public is struggling with, because we don't have a set symptoms. They're saying, well, maybe this is just numbness because I slept on my arm wrong. And so that's why I really enjoy doing these talks, is because I want to educate people that, yeah, if you have the risk factors and you're worried and it comes on all of a sudden, it's probably worth getting checked out.
On that note, Dr. Belagaje, you talked about pain, like with a heart attack. There is a stroke or like the aneurysm rupture where you have pain. Most of these are without pain, because there is a question in the chat about pain and strokes. Can you talk about that? I'm interrupting that one because I'm seeing it pop up.
No, that's a great question, and thank you for asking, and thank you for interrupting me. Please feel free to interrupt. So yeah, pain is typically not associated with the traditional stroke symptoms. But the caveat is that people are having a hemorrhagic type of stroke, especially with the aneurysm ruptures. They can develop pretty sudden onset of headaches, and these are going to be usually pretty bad headaches. It's not going to be your typical migraine or your tension type headache. It's going to be a sudden onset. Well, one moment I was fine, next moment, boom, I'm feeling this. And then usually people it's the headache plus other neurological symptoms as well. So if you have a headache plus other symptoms, it is always worth getting checked out urgently. But unlike heart attacks, majority of strokes are not going to hurt. And that's because ischemic strokes tend not to have as much pain, and they tend to be the majority of strokes. Great question. And so what I'm showing you now is kind of the map of the brain. You probably may have seen something similar in some prior talks, so forgive me if this is repetitious, but I think it's important to explain why people present with such different symptoms. So what I'm showing you is a part of the brain, and you can see that the brain is divided into different lobes and different parts, and each part of the brain has different functions to perform for the person. And each part of these different brain parts are supplied by different blood vessels. For instance, the occipital lobe is responsible for our vision. The connections that we get from our eyes take the initial shapes and colors and send them in through signals through the optic nerves, where they get processed in the back part of our brain to recognize to turn them into objects and faces that we're familiar with. It also takes words and letters and combines them into that we're able to read. The cerebellum plays is a part of the brain that is responsible for balance and coordination. So a stroke in this area of the brain, the cerebellum, which is the red part, would not cause vision trouble, but it would cause balance trouble, and vice versa. A blood vessel clot in the occipital lobe would cause primarily vision problems, but would not necessarily have balance and coordination problems. But a person who might have vision troubles may look like they're having trouble walking because they may be bumping into things and feel off balance because they're not seeing as well. But if they had a larger stroke that was covering, they might have vision trouble. They might have trouble hearing because it's being affected by the temporal lobe. The stroke can also affect the parietal lobe, so they might have trouble with numbness on one side of their body as well. And so that's kind of what makes stroke care challenging, because everybody's a little bit different in terms of their presentations. And this is just kind of showing you some MRI scans to show you the different blood vessels and kind of see how the strokes look like, the different ways that strokes look like on imaging. And I don't expect anyone to memorize this. This is not a thing, but what I want you to get out of this is that the strokes, depending on where the blood clot is, can cause strokes in different locations. And as I showed you on the previous cartoon, those different parts of the brain have different functions. So they'll present with different signs and deficits. But then they will also have different sizes. And that's also part of their the different presentations. A larger stroke area can cause more damage and affect more areas, so they'll have more symptoms. And on the other hand, a smaller stroke will not have, so they might have lesser symptoms. The other challenging thing that sometimes I get asked when I'm in the hospital is someone will ask me, like, let's say, doctor, is the stroke a big stroke or is it a small stroke? And the part that we struggle with sometimes in stroke care is that it's the severity of a stroke is based on two things. It's the size. The larger size affects more parts of the brain and causes more injury. But it's also the location of the stroke. If the stroke is in a very important area of the brain, like the brain stem, and a small stroke in that area can cause a significant amount of damage, where a patient might become comatose and become paralyzed all over their body. Whereas if that same stroke was in a different area of the brain, they might have much fewer symptoms. So it's a size and a location type. And that's really what I want you to see, appreciate from this illustration, I should say. So other than going through medical school, going through residency, how can the public know? And so there are some things that the different stroke organizations have tried to educate the public about, and I think it's important to be aware of these. So it's the suddens, and so remember, these symptoms with stroke is one moment you're fine, one moment you're not, and sometimes this can be challenging because a loved one may be home by themselves. When you went to the grocery store, you went on a trip somewhere, they were fine, they were normal. When you came back, they're presenting with stroke-like symptoms. We don't know exactly when that occurred, if it was a sudden onset or things like that. My thought process in that, and my advice is, if you're not sure, always err on the side of caution and treat it like it was a sudden onset. So the suddens include sudden onset of facial droop, sudden onset of trouble talking or understanding language, sudden onset of vision loss, sudden onset of dizziness, sudden onset of kind of paralysis, not being able to move. And then there's the stroke collaboratives, also the Gimme 5 for stroke, which are any of these deficits, trouble with walking, talking, reach, seeing, or feeling. If you have any of those 5 functions affected suddenly, chances are that you're having a stroke. And then there's the ACT FAST, which is through the National Stroke Association, which involves face, arm, speech, and time. And this
Dr. Belagaje.
Yeah.
Can you tell them about the enzyme? There was a question about, can you reclaim damage? So one of the reasons for getting to the hospital quickly, if you're experiencing these symptoms, is so that you can get the enzyme. Can you talk about that a little bit?
Yes, I will be coming to that soon.
Okay.
If you hold that question, it's an excellent question. It's important to the talk. We'll be coming to that on my slides soon. Yeah. There is the with the fast, there's the face. So if there's a facial droop, so if you're concerned, you have the patient smile, and if there's any unevenness to it, or they have a drooping of their face, that could be a sign of stroke. You have the person put their arms out and see if one arm starts to drift down, or they have trouble keeping it up, that would be a sign. And in speech, if they're having trouble, if their words sounding slurred, or if they can't get their words out, or they're not understanding what you're asking them, that could be thing. And then the T is for time, to remind you that this is an emergency, to call 911. And also the time is to remind that it's got to be a sudden onset. If this face thing is always gradual over 2 weeks, that's probably not a stroke. The other kind of sometimes is what I want to is TIA, because you might hear this either in the hospitals or in the medical literature. And this is a stroke warning sign, sometimes referred to as a mini stroke. Here, what occurs is that the stroke symptoms present, but they resolve within minutes to hours. And the technical definition is within 24 hours without any treatment. They resolve spontaneously on their own. And what's occurring is that as I kind of told you about with the blood clot, it's blocking off the blood vessel, and the body dissolves the blood clot on its own to restore blood flow to the brain. So before any permanent damage is done, the blood flow is restored, and people are able to return that function. They'll have stroke symptoms, and then as soon as the TIA is resolved, they'll feel back to normal. And a lot of people say, "Hey, I'm back to normal." Even though they're back to normal, we treat that like an emergency, because that's usually a warning sign that somebody's about to have a full-blown stroke. Similar to angina, which the chest pain that people that experience with a heart attack, we want to treat those and figure out why somebody's having a TI, so we can prevent them from having a stroke. And so if they're having the symptoms, typically 911 is being called, but by the time the ambulance gets there, people might feel better and like, oh, I don't need to go to the hospital. I'll just check in with my primary care doctor tomorrow. No, go ahead and get checked out, because the next time this occurs, you could be having a full-blown stroke. So other thing to be more concerned about when it comes to a warning sign about a stroke. So we'll talk a little bit now about risk factors associated with stroke. And the first kind of graph here was two-based. It's talking about dividing up people by their race, ethnicity, and as well as by age, the relative risk of having a stroke. And what we are seeing is that that there is a genetic component to strokes, that there's a reason certain blood vessels may be more prone to forming blood clots in them, and there's probably some other genetic risk factors, but non-Hispanic Blacks tend to have a higher risk of stroke compared to other races and ethnicities. But you can see it's still prevalent in relatively everyone has toots. And then when we look at them from an age standpoint, and this is dividing it by gender and by age, there are two things that I want to point out here, is that as people get older, there's an increased risk of stroke. And to me, that makes sense. That if we're talking about, when we talk about that, the causes of stroke, that if a clot is forming over time, the older you get, the more clot that can accumulate in those blood vessels. And so you're going to have a higher risk and risk of stroke as the clot develops over time. Also, strokes can be caused by troubles in the heart. And as we know that heart disease gets more prevalent as people get older. And so if there's more heart disease, there's more risk of an embolic stroke as people get older. This other graph is also important in terms of understanding what's causing from a gender standpoint. And there seems to be pretty equal initially. There might be a slightly gap in that 45 to 50 year where women tend to have a slightly higher risk. And that's not really well understood. There's thought that if you think about that time period, that's kind of the menopausal, perimenopausal. So they think there's a hormonal protection process probably going on, or excuse me, there's a protective hormonal effect that's occurring earlier, but as that menopausal period is coming along, that you lose that hormonal protection, and so slightly increased risk in women, but that doesn't kind of plays out as people get older as well. When we talk about risk factors for stroke, I think about them as modifiable and non-modifiable risk factors. So when we talk about medical modifiable risk factors, high blood pressure, diabetes, cholesterol, heart disease are the main things that we can treat and control. There's also lifestyle things, smoking, alcohol use, the amount of activity, the things that we choose to eat. Losing weight can be those things that we can do from a lifestyle standpoint. Then there's some non-modifiable risk factors. We can't control how old we get, or as we continue to age, there's going to be an increased risk of stroke. As I showed you on the previous graph, there's a certain race thing. We can't control who we're born to and the genetics that we inherit from our parents. A family history goes with that genetics stuff. Once you've had a stroke, it's people are at a higher risk of having it. We can't go back in time and erase it, but once we know that somebody's had a stroke, we can go and try to address all those risk factors. And then there's a geographic component to it as well, where we can't change our environment drastically to reduce that stroke risk. Let me show you that, which I think is interesting as well. This is a map from the CDC showing in the between 2000 and 2004 all the strokes that occurred in the United States. The darker the purple, the more heavy risk of stroke that is occurring. And you can see as you look at the slide that there's a lot of dark purple centered around here in the southeast, right here, starting in good old Atlanta, Georgia, and in our home state, and kind of spreading around throughout the southeast. And this has been known to stroke researchers for a while, and it has been dubbed the stroke belt of the United States, that this part of the country sees more stroke than the rest of the country. And we're not sure exactly why that is. Some of that may be due to our diet and our cuisine. Some of it is probably genetic. And there's some interesting research that people who come from families that have lived here, but then move to outside the stroke belt area can reduce their risk if they move by age 15 or so. But if they leave after that, that risk is not, it continues there. Subsequently, people come from different areas and then move to the area. They see some slightly increased risk. And again, there's a genetic component to it as well. But we think that there's a geographic component based on this data as well. And so now we're going to shift and kind of go back to the question about what to do if somebody's having a stroke. The first thing is kind of recognizing that somebody's having a stroke. And the things that I'm going to shift it back onto our patients that come in is that, you know, you've got to be able to recognize and or have that concern in the back of your mind and get checked out. The things I don't want to hear say is that, you know, it's just a heat stroke. That term is sometimes thrown around where somebody gets thing and they confuse a heat stroke from the strokes that we're talking about today. And those are two very different things. A heat stroke is usually just a temperature thing, cooling with water, people get back to normal. It's not going to cause any permanent brain damage, whereas a stroke can personally have it. I've had a light stroke. A stroke is a stroke, and once somebody's had a stroke, you're at increased risk of having another one. A light stroke this time does not mean that you're going to have a light stroke next time, and you might have a much more serious stroke or even more fatal stroke next time. And so we want to get people checked out. Saying, I didn't sleep on it, let me see if it gets better. No, if it has like that, I must be dehydrated, it will get better. My sugars, these are some of the things that I've heard patients say over the years. That I just feel bad, I don't need an ambulance, I just need to get my blood pressure under control. I'll just take an aspirin. I just passed out. And definitely don't say I need a cigarette. And I don't want to go to the emergency room. If you're having symptoms, please come to the hospital so that we can check you out. And the reason for that is that there are certain treatments, which I'll be kind of presenting, and there's things that are being done very quickly to be able to assess if somebody's having a stroke in addition to those initial signs and symptoms. So with our students and our trainees, we always say in acute stroke care, we have this mantra of time is brain. So meaning that if somebody's having a stroke, we want to get you into the hospital as quickly as possible so that we can diagnose it and potentially provide treatment. And if you think about those brain cells that are not getting the oxygen that they need, they're very sensitive to it. Every minute that's going by, hundreds of thousands, if not millions of brain cells are being irreversibly damaged. And we want to try to save as much as possible so that people can minimize the amount of stroke. When that occurs, you get to a hospital, we can do a scan of the head. And the purpose of the scan is to determine if somebody's having an ischemic stroke or a hemorrhagic stroke. Hemorrhagic stroke, the bleeding stroke, we'll see pretty quickly on the brain, we can say, and that we can put people in that treatment. We may not necessarily see that someone's having an ischemic stroke right away, but if we don't see the bleed or any other cause, then we can start initiating some other of our treatments for it. So it's important to get to the hospital as quickly as possible. So if someone comes in for a stroke, the first things that we want to do is do a scan on them, usually a CT. There are sometimes MRIs that are done very acutely, but those are usually done in the next day or two. They'll get blood vessel tests done to see if there's a blood clot or see if there's an aneurysm that has ruptured, if it's a bleeding type of stroke. And then this goes to that question that there is a treatment. This is a medication treatment that's called TPA, tissue plasminogen activator. So what this is an enzyme. It's a natural, it's a recombinant, so a synthesized form of an enzyme that is naturally found in our bodies that dissolves blood clots. And if you think about this, the purpose of this is, if you ever thought about when you've scraped your hand or cut your finger or anything like that, a blood clot forms there, but eventually that clot needs to go away so that new skin can grow, the new tissues can grow. The enzyme in our bodies that's responsible for dissolving that blood clot is the natural form of TPA. This medication is a synthesized form. It was first approved for treatment in 1996, in part due to some of the research we did here in Atlanta, both at Emory and our Grady Hospital. My colleagues were heavily involved with that, and we showed that this medication was beneficial. It has a time limit, and so it must be administered within 4.5 hours of onset. So this is not the onset of when we find the patient or when the patients come to the hospital. It's the onset of symptoms. So one of the things that we want to know when somebody's having the symptoms is when did it start? I previously gave you the example of a patient, somebody who might be at home, they look normal, family goes away on a trip, or they go to the grocery store, they come back and they find the patient several hours later with it. They're not able to talk, so they can't tell us exactly when that those symptoms exactly started. So what we use is the time lasting normal. And that's part of the reason that we say strokes are emergencies, because we have such a limited time window to be able to treat. We don't want somebody waiting at home. We don't want them to say, hey, I think I just had a light stroke. Let me see if it gets better. Let me sleep it off. No, we want you to come in so that we have this medication that we can potentially offer you. In certain situations, we can extend it further. There is a new medicine that's similar to TPA, which I'll talk about in another slide, but it's very similar. It dissolves the blood clots. The other things that we will do in the acute setting is blood pressure control. We don't want that blood pressure to go too high, especially if there's a bleeding stroke. Higher pressure, if you think about like a fire hose, higher pressure leads more water coming out. Same thing, higher pressure means more blood is coming out. So we're going to try to reduce the blood pressure. We're going to try to control the blood pressure in an ischemic stroke. We want to make sure that patients are getting adequate oxygenation. So there's the part of the brain that's not getting as much blood flow. And so there's going to be stress on the heart. There's going to be stress on the lungs. We want to make sure that those things are continuing to provide blood to the other parts of the brain so that they limit the size and damage that's done from the stroke. So TPA, also known as alteplase, that's the enzyme as we talked about. Don't need to know the specifics, but it converts this protein in the blood called plasminogen to plasmin, which dissolves the blood clots. More recently, there's a new medicine called tenecteplase, TNK, which we are now using in our hospitals. It is very similar to TPA. In fact, it works the same in terms of dissolving clots. The advantage of this medicine is that it seems to be a little bit easier to use. TPA is usually given over 1 hour, and it has to be given through like an IV. This TNK can be given with just a quick kind of bolus through a vein and done very quickly. And it lasts, it seems to be just as effective as the TPA that was been offered since the 1990s. In addition to the medications in the acute setting, if the clot is large enough, so it's in a bigger blood vessel, and we see that there's a blockage, we can go in surgically and remove that clot. And this is similar to what happens when people are having heart attacks, in that the cardiac catheterization procedure. That procedure involves people going through the groin, into the heart blood vessels, and then either removing the blood clot or putting a stent into the heart to allow blood flow to occur. Same thing can go on in the brain. Rather than stopping in the heart, we go further north up into the brain. My colleagues who do this procedure will shoot the blood vessel with dye to see where exactly the blood clot is, and then use their tools to remove the blood clot. And what I'm showing you here on this is a patient whose blood vessel seems to have a blood clot, and it stopped right here. And they went in and removed the blood clot to restore the blood flow. So you can see this entire area was missing on the pre-treatment blood flow. So this entire part of the brain was not getting the blood flow and oxygen it needed through this procedure. We were able to. Similar to the TPA, this is a time-dependent procedure. The sooner we can open up the blood clots, the less damage that is done to the brain. So that's the other reason we say time is brain. The good thing about these treatments is that we have a little bit more time than the TPA. We can go up to 8 hours, and in certain cases can go up even longer. But the sooner, again, we do it, the better off patients are. And this procedure is called thrombectomy. And I'm showing you another cartoon showing you the blood vessels that go in there. And what you're seeing here is that there is the catheter device is going in there to remove the blood clot. And it's kind of like a net, and it snares the clot, and then they're able to pull it out from the blood vessel. And kind of showing you here again, there's the blood that's going here. It stopped because of the clot. The procedure is done, the thrombectomy procedure. The blood clot is removed and blood flow is restored to that brain. The other part of treatment is the rehabilitation part. This is something that's near and dear to my heart. The benefit has been established through several research stuff. We usually like to begin therapy immediately while people are in the hospital. So we don't say, oh, you just had a stroke. Let's let you send you home and rest for a couple weeks, and then we'll start therapy. No, we want to start it while people are in the hospital. And then depending on the severity of the stroke, some patients may not be able to go home right away. They have to go to an inpatient rehabilitation facility where they get more intense therapy, and that can be continued in the outpatient world as well. The recovery is usually seen in the first couple weeks to months, but they can continue indefinitely. And I cannot stress that enough because, and that's something that's near and dear to my heart as well, because when I was in medical school, we used to believe that people had 1 year to recover. And that was the way I was taught, was that people had 1 year to recover from a stroke. And if they continue to have deficits past that year, those were likely permanent. We now know that's not true, that people can continue to improve. What we don't know is, we don't have all the tools, and we don't have all the right devices and therapy techniques to continue that therapies that are well. But this is an area of research, and several of those trials and information has been has come out of Emory, and we're continuing to study this more to offer our patients a fuller recovery and lesser disability. And this is just some of those trials that are kind of going, that we have microchips that interface with different brain computers for people who are more severely paralyzed from strokes, that we can insert chips that continue to devices that can activate for them. We have virtual reality games and stuff to put people in environments to enhance their physical and occupational therapy, so that they're doing exercises in a fun and more intense and challenging environments. And then we have various devices like transcranial magnetic stimulation that we're studying to see if we can stimulate the brain cells into rewiring in different ways. So I will end, we're almost done here, on prevention. So like I said, when somebody's had a stroke, there are increased risk of this happening again. And so we want to do everything we can to prevent that. What I typically approach is I think about what's causing that stroke. And that's why I kind of started about kind of showing you all the different causes for stroke. And what I do with our patients who are in the hospital is we run tests to figure out, okay, what caused them to have their stroke? And then if we have that particular stroke cause, then we can prevent that from happening again. So for instance, if they have large vessel disease, blockages in the carotid blood vessels, there are certain surgeries or stents that can be put into those blood vessels to minimize that the blood clots that are forming there, in addition to medicines to prevent them from having subsequent strokes. If they have a cardioembolic, a problem with the heart, there are certain medicines to prevent blood clots from forming in the heart and traveling. And if they can't take blood pressure medicines, there are certain surgeries and devices that can be put in the heart to prevent those clots from traveling up into the brain. So it's important to get that the testing done to figure out what's causing the stroke so that we can prevent the next one. In addition to figuring out what's that we want to treat those risk factors. And again, if you remember from my previous slide, we divide that up by non-modifiable, those things that we can't control, and the modifiable. There are certain things we don't control, like I said, how old we are, what our race is, what our genetics are like. But I want you to look at those modifiable risk factors. Those are all the things that we can do to prevent strokes. We can control blood pressure, hypertension. If people have cardiac disease, they can be on medicines, including blood thinning medicines. Diabetes is a risk factor. We can take medicines to control blood sugars or control our diets. If people have high cholesterol, we can get them on medicines or control diet. We can get people to stop smoking. We can get people to stop drinking or cut down their alcohol use. And we can get people to be exercise more and be more active. And risk factor modification, kind of generally, this is kind of a generic things that we want: blood pressure control, diabetes, cholesterol. So if somebody comes into our hospitals with the stroke, we want to make sure these things are, we're going to educate them about diet. We're going to counsel them to exercise regularly, at least 30 minutes a day, but sometimes hard to tolerate. And if they're smoking, try to get them to stop, either with the medications or try to get them into classes. There are the medicines specifically that we can use. We put people on antiplatelet medicines. These are prevent those blood clots from forming, usually common things like aspirin, Plavix, which many of you have heard of. That's what's going to be used in the majority of our patients. But in certain patients, they may need stronger blood thinning medicines, medicines like Coumadin or warfarin that you've heard of, or more recently, things like Eliquis, which are used for the AFib, those irregular heart rates or heart problems that can occur where blood clots form. We can get people on blood pressure medicines, and they can be on medicines like statins, which are Lipitor, Zocor, Crestor, to control cholesterol. So finally, how can you help? Share what you've learned today with others. I'm so glad that this is being recorded and things. Hopefully, if you found this, learned something, found this educational, worth your time, hopefully you will share this with friends and loved ones, because you may be able to save a life if they can recognize that they're having a stroke, or someone around them is having a stroke and they call 911. Definitely, we're constantly trying to find ways to increase stroke awareness in the community. You'll see our teams at various health fairs, various social events in the community. Donate that time and energy to increase. We can definitely make an increase. And then contact the university stroke team, which I had the privilege of being part of. If you have any questions or interested in any kind of research stuff, we have research studies that are dealing with acute stroke treatments. Emory has been involved with research that helped kind of find that first TPA medicines to show that there are medicines. We've pioneered the surgeries that were done to help show that the removing a blood clot through those thrombectomy procedures was beneficial. We've been active in stroke prevention studies, trying to figure out what the best medications are for. Not everyone is able to tolerate aspirin, or aspirin doesn't work for everyone. So we're trying to figure out who are the people that might benefit from other studies. We're doing studies on sleep apnea, which seems to be a risk factor for stroke. And then we're constantly, if somebody's had a stroke and they want to learn to get better, we have research studies on rehabilitation. So if you're interested in that, please reach out. If you are in the hospital or within the clinics and you qualify, oftentimes the team will contact you first. And I just want to say, when we reach out to you, if you do get one of those calls, or call one of your loved ones or friends, it does not affect how we care for you. These are in addition to what our standard of care is. What we use this is to provide medicines, or in the case of rehabilitation, therapies that are not currently available. We find that these things are safe. Otherwise, we wouldn't be offering them. What we don't know is if it's better than current treatment. So that's why that's why it's considered research. And then we find that we learn from these studies and find better treatments for our patients.
Thank you so much, Dr. Belagaje. I just have one question. This was
Yeah.
an excellent talk, and everybody was really engaged. I have a question. Do you have a number for the stroke team? A number we can call so that or even flyers or number to call for getting involved in some of those those studies you talked about, sleep
Yeah.
apnea, stroke rehab?
Absolutely. Let me give you, it's 404
404
778
778
3444.
3444.
And that's the stroke.
778. That's the stroke team.
That's the stroke team phone. Yeah.
778 3444.
Correct.